Hi class, this is your chapter 20 lecture. This is the part 2 lecture of the renal system. We're going to focus on fluid and electrolyte balance. So some of what we'll learn here is brand new, but some of it will be familiar since we've already learned about electrolyte balance. We learned about that with our cardiovascular system. We even learned about it a little bit with our respiratory system in terms of pH balance and how that ties to electrolytes such as potassium. So we will go through the whole chapter. Okay, so we do have multiple systems that are responsible for helping to regulate and integrate our fluid and electrolyte balance. And that tells us it's important. Anytime we have multiple systems to do something, it's really important. And we know that water is essential for life. So we do have several systems involved. Our respiratory and cardiovascular systems are able to respond really quickly. So they deal with problems that need to be dealt with right away. They're under the control systems of the nervous system, as well as those parasympathetic and sympathetic responses that we've learned about, tying to blood pressure, for example. But the kidneys also have a role in regulating fluid and electrolyte balance. Now, their actions are slower. And this is because they involve the actions of different hormones. And these hormones come from either the endocrine system or the nervous system. That's all a neuroendocrine is. It means it's a hormone that is produced under the control of the nervous system. For example, from the pituitary gland. We'll learn about that in our last section, but we will discuss two hormones today that are important in water balance. So by having a quick response, we have a way to deal with imminent threats, but we also have a more prolonged response that think of it as just being more of the way to keep everything smooth over a longer period of time. So, hey, we're at the end of the semester. So you could think of your respiratory system like the individual tests and assignments you took at the beginning of the semester when you didn't have that many grades. But now you've got all your grades or most of your grades, and there's not such an effect if you by one score anymore, because you've got a big weight under it to average it out. So that's kind of how the kidneys are working. They're able to function to give us more of our consistency. They are tied in correction though too. So I don't want you to think that it's all just based on making our kidneys function right. With regards to our fluid balance, our kidneys are able to initiate corrective measures too if we become hyperosmotic, for example. Okay, so our water intake and our water outtake are balanced. I mean, for most people, you subtract it out, it's zero. So where do we get our water? Well, you know we consume it. I've got a big glass of it right here. So we get most of it from ingestion, but we also generate water through metabolism. What is one of the products of cellular respiration? Water. We generate water through metabolism. And then in the event of getting an IV injection or fluid for whatever reason, of course, that could add fluid to the system. That's not normal though, right? How do we lose water? We lose most of it in our urine, but boy, we recover far more than we lose. A little bit of it is lost in our feces, and then a good amount of it is lost through our skin and respiratory system. It's actually surprising how much we lose through our skin and our respiration. In fact, when a person has an asthma attack, and I'll share my experience, I have pretty bad asthma. One of the treatments that they give me right away is an IV fluid infusion, because breathing fast, when a person goes into respiratory distress, they're going to breathe fast. We've learned about that mechanism, right? Trying to get more oxygen in and carbon dioxide out, the respiratory rate increases. But that means we're breathing water off. So a person that is suffering from any type of respiratory distress is at greater risk of dehydration. The elderly are at risk of dehydration. And this ties to the fact that they are not making as much protein, which means they don't have as much protein in their body to influence the osmoregulation. And specifically, the type of protein that elderly people suffer breakdown of, it's muscle. So just a little tying it into some of the clinical pathologies. Now, there are pathologies, illnesses that can result in water loss too. And that would include diarrhea. It includes vomiting. It also includes excessive sweating. And that can be due to a medical condition, but it also can be due to exercise or, prolonged heat. Now, the kidneys are designed to conserve water. You'll see throughout this lecture, every opportunity the kidneys have to get that water back, they will. And when we look at the amount of water that moves through our kidneys, most of it's recovered. Most of it's reabsorbed to our body. Okay, so on the left side, we're looking at water gain. On the right side, we're looking at water loss. So I'm gonna go right down to the bottom to begin with. We have an intake of 2.2 liters per day through our food and drink. We produce about 0.3 liters per day of water through metabolism. We lose almost a liter a day through our skin and lungs. About 1.5 liters a day are lost in the urine, and 0.1 liters per day are lost in the feces. So really the loss of water by the skin and respiratory system, it's not much lower than what goes out through the urine. So this is significant. Anytime we tip that respiratory rate, a person is going to dehydrate because we lose water through our lungs and through our skin. Now, if we add all these values up and subtract them from our intake, it's 0. So the kidneys are designed to conserve water. That is one of their prime jobs, is to conserve water. That means getting it back to our body through reabsorption. Remember from our last chapter, reabsorption is when we take anything from the filtrate in the nephron and move it back to the bloodstream. So that can be for water. It can also be for ions or glucose. Okay, so this kind of looks like a beer mug, kind of silly, but it drives the point. So as long as we have sufficient volume in our kidneys function. We have enough water volume or fluid volume to run them through our kidneys. But if we don't have enough, well, gosh, we don't have enough filtration rate to drive them through our kidneys. Think back to what we learned in chapter 19, what happens when we clamp down the afferent versus the efferent arteriole of the nephron. There's an effect on the glomerular filtration rate. If we do not have enough fluid, though, we don't have the pressure that comes from that blood pressure, the main driving force to get fluid through the nephron. So therefore, this needs to be adjusted by clamping of those arterioles, which the kidneys can do. So they will increase resistance to, which will increase pressure and hopefully offset the loss through getting it back into the body as opposed to losing it in the urine. So we can divert the fluid away from the urine. For the most part, once, let me think about how to say this. You will see that we can recover fluid from the collecting duct of our nephrons. But it is even possible to recover fluid from the bladder in extreme cases of dehydration, but that's not normal. That's definitely a pathology. That's not a physiology. So we have a number of ways that we can regulate water absorption through hormones, the kidneys, but also through the cardiovascular system, as we'll see. So volume gain, if we have too much gain, this is offset by just peeing it out, basically. We would produce more dilute urine. And you've all seen this, right? I mean, come on, we've all gone to the bathroom in the morning. Sorry to be a little bit graphic, but we've all gone to the bathroom in the morning and we notice that our urine is darker than it usually is during the day. Let's learn why. It's not all tied to drinking water. There's another reason why we don't need to pee as much at nighttime. Okay, so here's our nephron. Just to review the basic structures of it, we've got our glomerulus would be over here, surrounded by Bowman's capsule. So that's the renal corpuscle. It feeds into the proximal tubule, down the descending loop of Henle. Here's the loop of Henle at the bottom, which is where it's most concentrated, up the ascending loop to the distal tube, to the collecting ducts, eventually to the bladder. Now, looking at this top beige part, this represents the cortex of the kidney, so the outer part of the kidney. At this portion, so in the proximal tubule and in the distal tubules, the osmolarity is essentially isotonic to what is in plasma. So our filtrate is isotonic to the plasma at about 300 milliosmolar. But when we're in any part of the loop of Henle or the collecting duct, we progressively become more concentrated in osmolarity as we approach the loop of Henle or the bladder. And this ties to where water is reabsorbed and where the various ions are reabsorbed over the kidney, over the nephron. Different things go in different places. We wouldn't have evolved this very elaborate, windy structure if it wasn't necessary. Now, keep in mind that the vasorecta capillaries, those peritubular capillaries, are extensively interacting with the tubule, especially over the loop of Henle. Because what is the point, right? The whole point here is reabsorption to the bloodstream. So we need to have extensive interaction between the tubule and the bloodstream to provide that opportunity. Notice that the diameter is different. So effectively, as we decrease diameter, what does that do to pressure? We've learned this. So if we decrease the diameter, we are applying resistance, which increases the blood flow or filtrate flow here. So this is a way to help push it through. And notice it becomes more dilute when we get up the ascending loop of Henle, and then it remains fairly constant. Now, the collecting duct does collect urine from multiple nephrons, and then it leads to the urine, leads to the bladder. So we have our isoosmotic fluid coming into the proximal tubule at about 300 milliosmolar. As we go down the descending loop of Henle, the only thing that's moving here is water. So water is being reabsorbed. The decrease in the volume is to compensate for that decrease in volume in the filtrate. If the loop of Henle stayed the same diameter as it is in the proximal tubule, the pressure would be too low to move. We would lose flow of our filtrate. Think back to what we've learned about fluid flow from the very beginning of the semester. Flow is equal to the change in pressure divided by the sum of the resistive forces. So by decreasing the diameter, we are increasing resistance, which allows us to deal with the fact that we have a lot less fluid here because the water has been reabsorbed. Consequently, the ions are much more concentrated. So the loop of Henle is where the filtrate is the most concentrated. The urine can be just as concentrated as the loop of Henle, but it varies depending upon the needs and intake and salt balance of what's going on in that person. So we're at about 1200 milliosmolar as we go up the ascending loop, and now we're getting wide again because we're changing the osmolarity again. When we're moving up the ascending loop of Henle, this is where the ions are reabsorbed, but not water. But what's that going to do to, right? That's going to dilute everything. And so we get very dilute up in the distal tubule. And then finally, as we move down the collecting duct, we do have reabsorption of both water and solutes. And finally out to urine, which can range depending on circumstances. So I encourage you to make a table or a graph or picture, draw it out. The more times you do it, the better. That's how we get things in our long-term memory, where you know which ions and where water moves over the nephron. That understanding, along with the two hormones that we're going to learn in this chapter, really is the key to it. So if you're able to understand where water moves and where the ions move, together with our knowledge of diffusion and osmolarity, hopefully this comes a little bit, I don't want to say it's easy, but hopefully you've got enough knowledge under your belt now where you can see, okay, well, this makes sense. I've already learned about this. This makes sense. So please be able to describe the various locations where we have reabsorption of water and electrolytes. They're different places. All right. One of the hormones associated with water balance is called vasopressin. The name kind of tells us what it's doing. It's having an effect on the vasculature there. Another name for it is antidiuretic hormone. And diuresis is increased urine production. So it's making it it's decreasing the need to, let me start over. It's decreasing the volume of fluid that is going into the urine. That's the correct way to say it. It does this by acting on the collecting duct. And what it does is it punches aquaporin channels in there so water can be reabsorbed. Now, what's really cool about vasopressin is there's a dose effect. So that means more of it is produced when we need it. We'll learn about how that happens here, but we'll also talk about it next week in our last section on endocrinology, since it's a hormone. Okay, so vasopressin, it leads to the insertion of the aquaporin protein, which is the facilitated channel for water movement. It does this on the apical membrane of the duct. And interestingly, like other proteins in our body, it can be recycled. The aquaporin can be recycled and reutilized at a later time, as long as it's not damaged. So our blood volume and our osmolarity, we know, are picked up by different receptors. We've learned about this on our cardiovascular system. So we have osmoreceptors that are tied into this. So part of the reason why we don't pee as much at nighttime, I guess I should say urinate as much at nighttime, is because the expression of vasopressin exhibits a circadian pattern. And what circadian pattern means is different amounts at different times in a 24-hour period of time. So yes, we are drinking less water when we're asleep, obviously, but the expression of vasopressin is different then too. So this is why we don't pee as much at nighttime. So any of you that work the night shift and sleep during the day, or probably even worse if you're on a swing shift where you're changing, yeah, you may suffer the inconvenience of this circadian expression of vasopressin. And the inconvenience would be being woken up because you have to go to the bathroom during the day. All right, so diuresis again is increased production of urine normally, and it's going to be, it can be tied into the amount of vasopressin that is released. And of course, that will osmotically allow water to move through those aquaporin channels. So osmotic diuresis happens when we have a lot of solutes in our filtrate. Also, glucose can do this. So this is one of the reasons why diabetics have the increased need to urinate, because they have there should not be glucose in the filtrate. We recover it. But if we have too much in our bloodstream, then we can spill it over into our urine. But that's what it is. So it can lead to what's called polyuria, which is just excessive urination. So diuresis is normal physiology. Polyuria is not. That's an abnormality. And then polydipsia, this means thirst, excessive thirst. And why do we get thirsty? There is a reason. That is a valid question. We get thirsty. It is a behavioral craving tied to salt balance. So we get thirsty because our body knows we need to get water in to deal with too high of an osmolarity. Okay, so now we're looking at the collecting duct portion of the nephron. And then we've got two capillaries from the peritubular capillaries or the vasorecta shown. Of course, there would be way more than just two. This is just for simplicity. So as the filtrate moves down the distal tubule, this is where it is one of the two places where it is the least concentrated. The other place is in the proximal tubule. So we're at about 100 milliosmolar, but look how much concentrated it is. And it happens because of the free movement of water out of the collecting duct through aquaporin channels. And then that water follows over into the blood capillaries that are there because of osmosis. So notice too that the concentrations match. So we have the highest concentration of salt, of osmolarity, is where the collecting duct is the most concentrated. So that allows for the movement of water to try to dilute out that increased concentration in osmolarity. That's just simple osmoregulation. So now this is with the expression of vasopressin because the aquaporin channels are open. But in the absence of vasopressin, the aquaporin channels are not there. And then the collecting duct is not permeable to water and the urine remains dilute because the water is not being reabsorbed back to the body out of the filtrate. So absence of vasopressin, we pee a lot. With vasopressin, we're recovering the water back to our body. And our kidneys, again, are designed to do just that. And you know how important water is for life. Hopefully, after this class, you'll appreciate it even more. Okay, so looking at how and where these channels are, I'm just trying to clear some things off of my slides so they're not blocked. There we go. Okay, so we've got our capillary here, and then this is the apical side of the collecting duct, and this is the basolateral side of the collecting duct. So what happens is vasopressin is released into our bloodstream. Most of our hormones travel through our bloodstream. All the water-soluble ones do travel through our bloodstream. Some of the fat-soluble ones travel in the lymph, but or they travel bound to a water-soluble carrier. So our vasopressin is in the bloodstream, but it acts only on cells with the right receptor. And this is true for all hormones. I mean, hormones are very effective at tiny, tiny little doses because they bind the cell they need to target through a specific receptor. When vasopressin binds to its receptor on the basolateral side of the collecting duct, it activates the CAMP, second messenger system. So this is amplification. Second messenger systems are amplification. It's a way to get way more response through one molecule of hormone binding. Again, hormones are very potent molecules because of things like secondary messenger systems activating them. But what happens is when this CAMP is activated, it causes these aquaporin containing vesicles that are present in the collecting duct cells to move over to the apical side where they fuse with the membrane And in the process of exocytosis, will insert the aquaporin into the membrane here, and then water moves back in following its osmolarity. So here we go. We've got our water, which would be be less concentrated. Well, the water is in lower concentration in the collecting duct. The salts are getting more concentrated. The water moves through and it goes back on over to the bloodstream where it's reabsorbed. So that is how vasopressin acts by causing the insertion of aquaporin, which is already produced by the collecting duct cells, stored in vesicles, and it can be reused and reused and reused as long as it's not damaged. That is true for many proteins in our body because proteins are costly molecules to produce. Now, notice over here, the direction of flow between the blood and the filtrate is opposite. And that is true in almost all sections of the kidney. And it's necessary in order for us to have these mechanisms work. Okay, so looking at how, at our flow chart of how vasopressin ties into the conservation of water, we've got three mechanisms that can activate the hypothalamus in the brain to produce vasopressin. So the hypothalamus triggers vasopressin to be released from another part in the brain called the posterior pituitary gland, and then it feeds into what we just talked about, where the aquaporin channels are inserted in the apical membrane of the collecting duct, which allows water to reabsorb back into our body, which would concentrate the filtrate. So if we have a osmolarity greater than 280 milliosmolar, that is picked up by the osmoreceptors that are associated with the hypothalamus. They send a signal through an interneuron to the hypothalamus to secrete vasopressin. So that's one way. Another way that we can stimulate the expression of vasopressin, leading to aquaporin expression, is due to decreased stretch. And if the blood volume is reduced, then our stretch receptors are not going to be firing as much, right? Stretch receptors fire when they are stretched. We learned about this in our muscle section. So when we have a small blood volume or a decreased blood volume, these stretch receptors aren't firing as frequently as they should. That is picked up by a neuron that sends the afferent signal to the hypothalamus to make vasopressin, to increase the expression of aquaporin, to recover that water, to get our blood volume back up. Notice that our osmolarity here is lower than what it should be for our average plasma. So right, 280 is less than 300. The third way that we can stimulate the expression of vasopressin is by decreased blood pressure. And that ties with the decreased stretch response too. Now, the decreased pressure will be perceived by the aortic and the carotid baroreceptors that we learned about in our cardiovascular system. And they send the signal to the hypothalamus to increase the production of vasopressin. So that is how vasopressin is regulated and stimulated. Okay, so our kidneys use what is called a countercurrent multiplier exchange system. That is a mouthful to say. And basically what this means is the material in the filtrate is moving opposite in the direction of the blood. And this is necessary so that we have the right osmolarity and dynamics for reabsorption. So as our filtrate comes from the proximal tubule down the descending loop, it becomes concentrated because there is movement of water out of the descending loop of Henle because aquaporin is present here or can be induced to be more present. So we have movement of water over into the capillary. So that will dilute the osmolarity in the capillaries as that water moves over. Oppositely, it's becoming a higher concentration of salts in the filtrate due to the exiting of water. As the filtrate moves back up the ascending loop of Henle, now there is not movement of water. Notice the aquaporin channels are closed here. That's not the job of the ascending loop of Henle. The ascending loop of Henle is permeable to ions, not to water. The descending loop of Henle is permeable to water. So our ions are able to move back to the bloodstream. Even here, they're going to go back to the bloodstream. It just looks a little weird, but it's going into the interstitial fluid, which then goes to the blood. So that is a countercurrent exchange system. So it's important to understand that different parts of the nephron are permeable to different materials, typically water versus the ions. So looking at that a little bit closer, so we're going to begin down here. So we've gone down the descending loop, and now we're coming back the ascending loop, where water cannot move. Again, the ascending loop is not permeable to water, but it is permeable to the ions. So we get movement of sodium, potassium, and chloride through a channel here. So we're seeing the reabsorption of salt, which then concentrates the salts inside the cells of the epithelial lining, and then osmolarity will allow, or diffusion will get our materials, our ions back to where they go following their gradients. So chloride will diffuse out, potassium diffuses out. We've got co-transport between the sodium chloride, and then we've got our pump to get things back when there is, when we don't have that gradient to facilitate it. So consequently, the fluid leaving the ascending loop of Henle is now quite dilute because we've moved the ions out of it and have already put more water in it going down the descending loop. Okay, so looking at that again, I'm showing you the same figure because it's important. So the descending loop of Henle is permeable to water. So it facilitates the reabsorption of only water. Where the ascending loop is opposite, it is permeable only to the electrolytes, but not to water. Now our capillaries are permeable to both. And so they receive the material following the gradients and osmolarity. So our filtrate comes in at about 300 milliosmolar, and it's concentrated as the water moves out. We get down to the loop of Henle, and then back up the ascending loop now. There's no water movement here, but we do have movement of the electrolytes back into the vasa recta, into those peritubular capillaries, which then concentrates it. So the fluids are moving opposite directions, but notice the concentrations match. Okay, so now we'll talk about what happens when we consume too much salt without getting that extra water in to balance it out. So this can happen through eating a really salty meal. It also can happen if a person is dehydrated for whatever reason, like maybe they're sick and vomiting and they're losing fluid. That could be a reason too. So if we ingest a very salty meal, but we don't drink a bunch of water, we're going to increase our osmolarity, but have minimal effect on the volume. So that does make us thirsty, but it does result in the release of vasopressin. This is one of the stimulus that we looked at that initiates the production of vasopressin from the hypothalamus. So then that leads to the expression of the aquaporin channels and the apical side of the tubule, facilitating the reabsorption of water. Now, how this ties to thirst, this is a behavioral mechanism that is tied to these hormones, because once we're thirsty, we're going to decrease water, and that ties right with the reabsorption. And our kidneys have the job of conserving. So if we're thirsty, we increase our water intake, but then our kidneys are going to say, hey, we need this stuff. We're going to get it back into our bloodstream instead of eliminating it in the form of urine. So as we increase water, the extracellular fluid volume is going to increase. And now the kidneys are going to help us return to our normal osmolarity. This is a slower, delayed response than is what's seen with the cardiovascular system. As our extracellular fluid volume is increased, the lymph vessels are going to pick that up and return it back into the cardiovascular system, which will increase blood pressure. And that will trigger the different reflex mechanisms that we've learned about in the cardiovascular system to lower the blood pressure. And this happens quickly. So we've got a slower response coming from the kidneys and a quicker response coming from the cardiovascular system, resulting in getting us back to a normal blood volume as well as a normal pressure in the cardiovascular system. So our normal concentration of sodium is 135 to 145 milliosmolar. But sodium is capable of distributing itself evenly between the plasma and the interstitial fluid due to the various pumps and channels that we've learned about. Okay, so now we're going to talk about another hormone called aldosterone, and it is tied into sodium and potassium balance. So we've got absorption of sodium, but secretion of potassium. So they're going different directions. So aldosterone is a hormone as well that travels through the bloodstream. It binds an internal receptor. And once this happens, it initiates a transcription mechanism to produce, to turn on protein synthesis to make all these channels and pumps that are needed. So we get the creation of new channels that are on that apical side of the membrane. We've got, so this will facilitate, we've got our potassium channel here. So potassium will flow out. Sodium is going to be reabsorbed. And then we've got our sodium potassium pump, and as well as more copies of it to move these materials against their gradients. So aldosterone is going to change the quantity of these channels and pumps that are needed to move sodium and potassium. And what it results in is we get sodium reabsorption. So sodium is being reabsorbed out of the filtrate back to the body, but potassium is being secreted. So they're moving in opposite directions. And this is happening at the collecting duct, well, the top of the collecting duct and the distal tubule. Okay, this brings us to the renin-angiotensin pathway, commonly called the RAS pathway. And it's tied to these juxtaglomerular cells that are, so these are the nephrons that are deeper in the kidney, but they secrete an enzyme called renin. And this happens when blood pressure is low. So if blood pressure is low, we would want to get fluid back to it to increase pressure. So it activates a series of precursor proteins. So renin changes angiotensinogen to become active. So this ending here, OGEN, this is telling you that this is a precursor protein that is not yet activated. And many proteins are produced this way. That way they can be modified quickly by a cleavage, by cutting something off, or a quick refold, which is a lot quicker than making it start to finish. So renin converts angiotensinogen into angiotensin 1. And then angiotensin converts the ACE enzyme. Well, it is the ACE enzyme. That is it. Angiotensinogen converting enzyme. It changes angiotensin 1 to angiotensin 2. So we need renin to activate to produce angiotensin 1. And then the ACE enzyme converts angiotensin 1 into angiotensin 2. So you may have heard of a category of blood pressure medications called ACE inhibitors. This is where they would act. Okay, so what stimulates this? We've got a few different factors that can stimulate this pathway. Well, the granular cells in the nephron are able to perceive even smaller changes in the blood pressure. So that's one of the stimuli. So I think of them kind of like barioreceptors, in that they're always sensing something, and we're looking at a change in the frequency. It's not quite the same thing, but that's an analogy. Another stimulus would be coming from the cardiovascular control center in the brain. And then we can get paracrine feedback too from the macula densa cells that are associated with the nephron. So let's see. So what happens once we activate it? Well, so angiotensin 2 is the outcome of that pathway. Well, it produces aldosterone. And aldosterone is made from the adrenal glands, and these sit right on top of the kidneys. So we have one adrenal gland on top of each kidney. So we have two of them. And then that's going to increase blood pressure by increasing vasopressin secretion, which will insert those aquaporin holes to get us reabsorption of water. Angiotensin 2 also does stimulate that thirst behavioral mechanism. So we consume water to increase our fluid volume. It also is a vasoconstrictor. So we close down those blood vessels or clamp them down, and that will increase pressure. Now, the cardiovascular control system does have a play in regulating the activation of the receptors for angiotensin 2. So this is under sympathetic stimulation between the heart and the blood vessels. It also acts on the proximal tubule to facilitate sodium reabsorption. Because what will that do? Well, if we reabsorb sodium, water is going to follow due to osmoregulation. And then it's tied in with I don't think we've learned about this exchange system yet, the sodium proton exchanger, NHE. So we've got different categories of medications that are used to treat blood pressure. So the ACE inhibitors would prevent angiotensin 2 from being produced, and then we eliminate all these effects. We've also got blood pressure medications that are inhibitors of renin. So then we would not make angiotensin 1, which then we don't make angiotensin 2. So sometimes it's necessary to try a patient on different types of blood pressure medicine, because they can have a different reason why their blood pressure is high. So typically, a person is put on a medication for about 3 months. You need to give it a good amount of time to have an effect, but then they'd be brought back in the clinic, and maybe their dose would be increased. But the good news is we have different categories of medications. So hopefully something would work for a person, but it may take trying different medications. Okay, so let's look at that pathway. And it's complicated. It's involving a lot of different systems in our body. We've got, well, let's see, we'll begin up here. So we've got decreased blood pressure. So the glomerular filtration rate is going to be lower due to that decreased pressure. So that means it's going to slow down the transport of the ions that are moving through the bloodstream. That is picked up by the macula densa cells that are in the distal tubule that then activate the paracrine stimulation of those granular cells that are associated with the afferent arteriole of the nephron. So that would increase the sympathetic activity, and that also ties with the cardiovascular control system. So our granular cells are the ones that produce this enzyme renin. And angiotensinogen is made by the liver, but it's always in the plasma. So once renin is present, it will convert the angiotensinogen that is in the plasma to become angiotensin 1. And then we need our ACE enzyme, angiotensin 1 converting enzyme, to produce angiotensin 2. And now we have all those effects that we just summarized coming from angiotensin 2. So it acts on the arterioles to cause vasoconstriction. It acts on the cardiovascular control center to increase sympathetic stimulation, which would increase our heart rate. That would increase our blood pressure and movement of fluid. It acts on the hypothalamus to make us thirsty, so we hopefully drink. It would increase the expression of vasopressin through the hypothalamus also, which would allow us to recover more water from the filtrate through reabsorption. Angiotensin 2 acts on the adrenal cortex to increase aldosterone, which increases sodium reabsorption, and then the water follows. And then also there is a direct effect of angiotensin 2 on the proximal tubule of the nephron, which is associated with increased sodium reabsorption. So the net effect is that low blood pressure is going to trigger the release of renin, leading to the production, providing there is ACE enzyme, leading to the production of angiotensin 2 that has a broad effect in trying to increase our blood pressure and maintain our fluid volume and osmolarity through these variety of pathways. Okay, another group of molecules are the atrial natriuretic peptides, ANPs. And there's a group of them. But these work opposite to aldosterone. So they're going to result in sodium excretion. Aldosterone is about sodium reabsorption, so the opposite effect would be excretion, and then the water will follow it. So it is triggered when we have our stretch receptors triggered through increased blood volume. That is picked up by the cells in our cardiovascular system through the stretch receptors. So we have a variety of different peptides in this group that act on the hypothalamus, which would decrease the expression of vasopressin, which would we wouldn't be recovering our water as much. They act on the kidney to increase the filtration rate, but also to produce less renin. So we're not producing our angiotensin 2 effects. They act on the adrenal cortex to produce less aldosterone. So it's going to, instead of favoring sodium excretion, or sodium reabsorption, we are now favoring sodium excretion. We're going the other way. and then they act on the medulla oblongata, which is where the cardiovascular control system is, which will in turn result in decreased blood pressure. All of these are going to increase the excretion of sodium, chloride, and water. So aldosterone is mitigated by the effects of aldosterone are mitigated by these ANP peptides. And this makes sense, right? Because we have to have a way to, if aldosterone just kept going and going and going, we would go too much in one direction. So we have to have a balance to tip the scale back the other way. Okay, so how does this tie to potassium? Well, aldosterone is associated with potassium balance. And we know that the condition of hyperkalemia, which is where we have too much potassium in our blood, it acts on the adrenal cortexes, and it leads to the production or the release of aldosterone. And then we've got the effects of aldosterone. So that will result in an increased activity of our sodium potassium pumps. So we're going to have more potassium secretion, which eventually will lead to potassium excretion. But a side effect of this is reabsorption of sodium because of that sodium potassium pump. So hyperkalemia is associated with cardiac arrhythmias. And these can be fatal cardiac arrhythmias in the setting of too much potassium. Not to be morbid, but to give you an example of one of the ways that potassium is used, is it's one of the methods utilized for capital punishment. And it does it by causing these arrhythmias and muscle paralysis eventually. The opposite condition, hypokalemia, well, this is when we need more stimulus to get us to threshold in our nervous system. So hypokalemia is associated with muscle weakness and the failure of respiratory muscles. So in my case, I have asthma. I also have low potassium. I have hypokalemia. And that is due to another problem. But when I have an asthma attack, it is amplified because of the hypokalemic response on my respiratory muscles. So I'm able to keep my oxygen saturation pretty good, but it puts a lot of effort on my body. And I've actually had to be intubated 2 times for a respiratory failure due to this. Not because my oxygen saturation plummeted, but because I built up so much CO2 in my body that I became acidotic. So hypokalemia is associated with people becoming acidotic. Additionally, some of the medications that are used, the rescue inhalers that are used to treat asthma, they cause hypokalemia too. So it's a triple whammy for me and many other patients that have similar conditions. Hypokalemia can cause cardiac arrhythmias as well. Arguably, hyperkalemia is more difficult to manage. Hypo is managed by giving it to the person, but it's hard to get it out once it's there, too much of it. So anytime we have disturbances in our potassium balance, it can be associated, or let me say that the other way, problems with kidney disease, diarrhea, or the use of diuretics, which can cause us to urinate, that can affect our potassium balance, and then that can affect our blood pH. So potassium is going to increase hyperkalemia. Too much potassium, it increases our resting membrane potential. So that means we're closer to the signal, right? If this is our baseline and our threshold is here, you know, we've got that amount of space. But if we start closer, we don't need as much signal to get to threshold. So hyperkalemia is associated with hyper excitability in our muscles, including the cardiac muscle. Now, cells become less able to repolarize in the setting of hypokalemia. And this is because there's still too much potassium. It simply cannot get back to resting membrane potential because of that excess potassium present. Right? Potassium is supposed to be high inside the cells, not in the plasma. So what happens in hyperkalemia is the muscle contractions eventually become smaller and smaller, and that is where the cardiac arrhythmias can come in. The normal amount of potassium in the blood ranges from 3.5 to 5 milliequivalents per liter. That's what this MEQ, milliequivalents, and that's an international unit that's used all over the world. So most people are sitting pretty in this range. With just to give you some numbers, with the medical conditions I have, I take 80 milliequivalents of potassium every day. That's equal to like several dozen bananas. I'm very rarely above 3.5. My potassium sits at about 3.4, 3.5. But if I have any type of respiratory distress, or potassium loss, I'll drop it down very quickly into a critical low level, which gets me in the hospital. It's usually no problem. They just give me some potassium and monitor me. But potassium has a big effect on our muscles. So why are we talking about this in the kidney section? Well, because of the reabsorption of these ions. So let's talk a little bit more about these behavioral mechanisms, right? Thirst leads us to drinking to replace fluid loss, but also having low sodium stimulates another behavior. It stimulates us to want salty foods. So when our body knows it needs salt, we get that craving for salty foods. And so that's associated with lower levels of sodium in the plasma. We see many examples in the animal kingdom where animals that live in the desert, for example, have developed mechanisms to prevent dehydration. I mean, some of the desert rats, they literally urinate crystals because there's so little water in there because they need to conserve that water. Many desert animals are also active at nighttime, and so they've got other behavioral mechanisms too to avoid dehydration. All right, so our normal pH of the plasma ranges between 7.38 to 7.2. So we've got a range there. And you know what happens with acid. Acid can denature a protein. And if our proteins are denatured, we've lost our structure, then we don't have the function either. So we lose that tertiary structure through denaturization due to the presence of too much acid in our body, or even too much base can do that too. So our body is very in tune at trying to regulate the acid balance. So that's why we have multiple systems in our body that are tied to regulating pH balance, right? We've got our respiratory system as well as our renal system. An acidosis is when we're too low and the neurons are less excitable, and it's associated with depression of the central nervous system, where we need more of a stimulus to have an effect. And I can tell you, when I've been in acidosis, it feels like I've got elephant legs to move them. I mean, it's really, really hard sometimes to even move muscles. And alkalosis is when we're above 7.42, and this is opposite. So now we're in the hyperexcitable category, and this can lead to tetanus. So alkalosis can lead to muscle tetanus, including the respiratory muscles. So pH disturbances are associated with potassium balances, problems in our potassium balance. In my situation, it was actually pretty crazy that I had potassium deficiency for about 10 years before they diagnosed the cause. And as a medical educator, it's really frustrating because there are few causes of potassium loss. The doctor caring for me should have looked more at my acid-base balance since I had a chronic potassium loss. So I unfortunately had a number of hospital stays when I was in graduate school, all tied to an acidosis, a metabolic acidosis that I didn't know I had, but it presented as and tied in with having very low potassium levels. And now I take my daily potassium and I'm usually fine. Okay, so pH balance in the body. We have other factors too. Some of our fatty acids and amino acids contribute acid, right? Amino acids, they're acids, or the acidic amino acids. So we get an input of H pluses there. Also, we can get it through our metabolism. We've talked about what happens when we have too much carbon dioxide mixed with water that produces acid. So those would result in decreases in our pH balance. So our body compensates with a number of mechanisms. We have the carbonate buffering system that's in our blood. I mean, that's how most of our carbon dioxide travels. We've also got proteins work as buffers, or some proteins. Hemoglobin, the phosphates do that are in cells. Even the ammonia that's in urine are factors that are important in regulating the pH balance. And then we've talked about what happens with ventilation, where when a person is having respiratory distress, they can build up carbon dioxide, which with water produces acid. And then, of course, we've got the effects in the renal system tied to the potassium pump that we looked at. So we also want to think about, though, when we're talking about pH balance, we don't want to only think about acids and buffers that are in our bloodstream. We want to think about the effects of other things we're putting in our body, such as antacids, for example. They have an effect on our bloodstream. So our pH balance is tied to the presence of these buffering systems, including that coming from our proteins, the phosphates, and our HCO3 molecules. And even when we have pretty moderate changes or small changes in our pH, this is great. I mean, our buffering systems are efficient at being able to neutralize or counteract those increased H pluses that are produced. So with our ventilation, with our respiratory system, it's able to fix about 75% of the pH balances, but it also can cause them, as I've just given you the example of with somebody who's in respiratory distress. So ventilation is able to correct pH balances through changing the breathing rate, either more or high, depending which way we're going. And then we've got our reflexes that are tied to ventilation also. Our kidneys, on the other hand, they do this by using ammonia and phosphates. So our respiratory system is doing it by changing the respiratory rate, which is going to have an effect on carbon dioxide and acid and potassium balance. But our kidneys are doing it more through the action of the ammonia ion and phosphate buffers. Phosphate buffers are pretty effective buffers. So let's look at what happens when we have a respiratory compensation for acidosis. So a metabolic acidosis is coming from the kidneys, as opposed to a respiratory acidosis that would be associated with breathing rate. So if we have too much plasma, that means our pH is too low. The chemoreceptors are picking this up. They will feed it into our respiratory control centers that are in the medulla, which then increases the action potentials of our somatic motor neurons to target our respiratory muscles, which will increase the rate of breathing excuse me, but also how deep we're breathing, using more of that capacity to exchange air. And that decreases our concentration of carbon dioxide. With our, if we have an increase in carbon dioxide, the chemoreceptors are going to pick that up, feeding in the same pathway. Now we've got two negative feedback mechanisms because we don't want to keep going into alkalosis. It needs to get turned off because it will go into alkalosis if it's not turned off. So once we get back to our normal concentration of carbon dioxide in the plasma, it sends a negative feedback loop back up to the central chemoreceptors, which will turn off the stimulation. And then also we have a negative feedback loop associated with the carotid and aortic chemoreceptors that are turned off when we get back to that corrective action too. Looking at how our kidneys compensate for acidosis, so we're looking at the filtrate now on this side. This figure is flipped from how the other figures were in your textbook. But we've got an acidosis, so we've got too much H+. And what's happening here is the HCO3 is going to be reabsorbed back into the bloodstream for one. But we're going to see this, this reaction that we've been talking about with carbon dioxide and water, where we produce H+, and here is how we make the HCO3 that is reabsorbed to the bloodstream. And then the H+ would be released in the urine, decreasing the concentration of it in the body because it's not going back to the bloodstream at this point. The H pluses can be picked up, absorbed with the ammonia ion, and then secreted in the urine. So here's an example of one of these phosphate buffers, H2PO4, that's a phosphate buffer. So our kidney is able to secrete H+, where our urine buffers it too by the presence of ammonia and phosphate. And then we've got the return of the bicarbonate HCO3 ion back to the bloodstream, which would be able to neutralize any excess H pluses in the bloodstream. So this is a long-term fix. The respiratory system is going to do it quicker, where the kidneys are going to take more of a long-term approach, but that gives us a nice, well-rounded protective reflex and compensation mechanisms. So looking at acidosis on the left versus alkalosis on the right, we've got our, so this is very similar to what we just looked at. We've got our reaction between carbon dioxide and water with carbonic anhydrase to produce the carbonate ion, which then is going to be reabsorbed back to the blood. But it uses this co-transporter as part of the mechanism, which then puts the sodium chloride back into the cell here. When we have too much H+ in the interstitial fluid, it feeds the pathway this way. It feeds it towards the production of the bicarbonate. And then the H pluses are pumped out through a proton pump into the urine. And then also they can be pumped out through the potassium acid pump as well. So that will result in potassium being reabsorbed because they're moving in opposite directions against their gradients. In the situation of So just to sum it up, so in acidosis, the H+ is excreted, but we're reabsorbing carbonate and potassium. In alkalosis, it's the other way around. We're excreting carbonate and potassium and reabsorbing the H pluses. So we're reabsorbing the H pluses back into the bloodstream, but we're secreting the potassium and the carbonate ion, utilizing some of these same channels and pumps that we've seen before. So that is the difference between acidosis versus alkalosis. We are talking about different cells that are involved in these reactions. So acidosis is associated with the type A cell, where alkalosis is associated with the type B cell. So that's why we have the expression of the different channels and pumps on the different cells. So to give you a table, this is from a different textbook, but I think it sums up kind of nicely a little bit of what we've been talking about. So we've got respiratory and metabolic acidosis, and then the same for alkalosis, but it gives you a nice summary of what's happening with the carbon dioxide, acid, overall pH, and the carbonate ion in each of these. It is possible for a person to have both a respiratory and a metabolic acidosis. I'm one of those people. I have the kidney problem, which gives me my metabolic acidosis, and then asthma can lead to a respiratory acidosis. All right, so what are some of the other causes of metabolic acid pH balances? Well, the consumption of a lot of these things, right? So people that are taking a lot of Tums or antacids or Rolaids, that can lead us to alkalosis. So these are not medications that should be used on a daily basis. These are things that should be used sparingly, or for short periods of time. It's always best to see a doctor and find out if there's something else that can be done other than treating it this way. Acidosis is associated with the loss of carbonate, and we can get that through things like diarrhea, or alkalosis is associated with vomiting. Trying to give you a little bit of a funny cartoon to wrap it up with here. All right, class, that's it for chapter 20. I hope to get this back out to you really quickly. Zoom is taking a long time this week. I don't know why, and I apologize for that, but I hope you're well. I hope your families are safe, and I'll see you soon. Bye-bye.